Hi, this is Barbara C. Phillips with Nurse Practitioner Business Owner. And today I'm sharing a replay of a webinar that we did on June 20th. Now, normally I don't share these on YouTube, but this one is pretty important and there's been a lot of requests, so I am sharing it. So this webinar was on remote patient monitoring. Now, we've worked with Don and Joe Self for a while on remote patient monitoring. And in fact, Don is known as a coding and reimbursement guru, which does a lot of our webinars. However, one of the things that we talked about in this particular webinar is how they came up with a program so that nurse practitioners and PAs could basically save that 15% that you lose from insurance companies and particularly from Medicare, and you can kind of make that up. And so here's that webinar. If you have any questions, you can reach out to me, or I will leave a link in the description so that you can get a hold of Don or Joe Self. All right, enjoy the replay.
Hello, everybody. As we said, my name's Don. This is Joe. We're here to talk to you today about remote patient monitoring and how it benefits your clinic as well as the patients. First off, you need to understand Joe and I are not attorneys. We're not doctors. We have no clinical training. We have been teaching seminars. I've been teaching seminars for 39 years. In fact, that's about how old Joe almost is right now at the same time. Right, Joe? And so I'm going to be going over a lot of information tonight. First thing I want to talk about, though, is CPT code. You have different codes that you have for PM. Some of them are accepted by some carriers, and other codes are accepted by other carriers with different definitions. For instance, code 99091 is an all-inclusive code. And, excuse me, it's basically encompasses everything regarding the RPM. It encompasses the equipment, the training, the setup of the patient, and it encompasses the time spent in the month. But this code requires 30 minutes, where the other codes only require 20 minutes, and there's additional codes you can use. The difference is on this all-inclusive code is it generally pays much better overall than one set of the other codes. Like in Texas, for instance, Medicaid, I believe, is paying $181 this year for this code. And in order to get to $181, if you're billing out with the other codes to Medicare, for instance, it's going to take a couple of 99458. So I'm going to go into detail on that. But I just want you to understand that when you're dealing with these PM, there's different codes depending upon which carrier you're dealing with, and we want to make sure that we find which carrier are paying which codes for you. Before we get into that, I want to make sure I stress something to you, because every time I'm talking to nurse practitioners, it seems like so many are undervaluing their time. And your time is valuable, extremely valuable. As a physician, they generally should be generating about $505 an hour for primary care. Nurse practitioners, you should be generating at least $360 per hour, probably closer to $425 an hour, by the way, but at least $360 an hour if you're doing what the insurance carriers are willing to pay you for. And that's what I'm talking about, is make sure that you're getting what you're worth, okay? And is this what you're getting right now? No. Unfortunately, most of you are not getting that. In fact, just this past week, Medicare released, or CMS released, the 2022 data, and so therefore I can take a look and see how much the average nurse practitioner is generating per Medicare patient in a year in the country. And you're looking at about $236, less than $240 a year per patient. And that's not nearly as much as it should be. That's because, well, one of the reasons is I don't think that some of the providers in the country realize is that Medicare patients are about 4 times to 5 times, at least 4 times more profitable than any other patient you can see in primary care. Now, that may not be the case for mental health. It may not be the case for surgery, but it's definitely the case when we're talking about primary care services. And yeah, I did say at least 4 times more. And especially if we're talking Medicare Part B. Like I'm an old guy, so I'm on Medicare Part B. And if you've been sitting in on my webinars, seminars with the NPBO for a while, you've probably heard me say this several times. And I'm very serious about this right here. Overall, you should be generating in your own practice about $1,754 per year per Medicare Part B patient if you're in primary care. Now, again, that's not what you've been averaging. You've been averaging around $234 a year. And I know by taking a look just at some of these numbers right here, some of these are working in some of these nurse practitioners are working in uh, facilities like RHCs, FQHCs, and that's usually where you're going to find like the $57 and the lower amounts. With the ones that's making the more, $226, 185, 184, 235, those are probably the ones in primary care. But still, overall, that's much less than $1,754 a year where you should be. And this right here kind of gives you, and some of you have seen this before, so I'm not going to spend a lot of time on it. This should give you an idea if you're just doing primary care preventive services and you're making about 15% less than the physicians do, because that's what these numbers over here are, is 15% less than these over here in the actual collections coming in from Medicare, you should be generating about $1,754 a year. And you'll notice this does not even include some of the things you're doing in the practice, like EKGs or spirometry or giving patients injections of Depo Get Better in their butt or their arm. It doesn't include things like pap smears or well woman checks or breast exams, signing home health certification, removing impacted serum from the ears, etc. But just based on that $1,754 a year for mostly the primary care services that Medicare expects, you're looking at 200 patients, meaning about 350,000 a year income just for Medicare. That's not even including the other 20%. But as Joey says here, wait, there's more. I always liked Joey. He's always had the greatest expressions on that TV show. What you may not realize, a couple of years ago in 2022, there were 65 million Medicare patients in the country. 57 million of the 65 were on Medicare because, like me, they got past 65 years old. And about 8 million were on there because of disability. So how many medical providers do you think 2 years ago were doing RPM? Out of that, all the medical providers in the country, only 11,278, and that's physicians, nurse practitioners, etc. 11,278. And how many patients do you think got the RPM that year in 2022? 1.3 million out of the 65 million. So the thing is, a lot of your patients are not getting RPM that need it. And Medicare has tried to help out in this area because they classified RPM in the same category as chronic care management. Now, what does that mean? Well, there's only 3 services that you can job out to another company and let them do the work for you, or you can still do the work yourself. In other words, only 3 things. One is chronic care management. Another one is remote patient monitoring. And the third is remote therapy monitoring. Just this morning, I was talking to one practice, and this afternoon, another one that had ultrasounds people coming into their office that they were paying them to do with ultrasounds on their patients. And I had to tell both of the medical providers, in this case, both of them, no, one was a doctor, one was a nurse practitioner. You can't do that. That's called pass-through billing. The problem is every single day, if you're in your own practice, you got salespeople coming in and trying to convince you to do something that's going to generate income, but they're not always telling you the truth. This is one of the reasons why I think that Barbara turns to us a lot for this advice, because she knows we're going to research everything to make sure you don't get in trouble. Because all we got to do is get one of y'all in trouble, and then Barbara's going to be putting hurt knots all over Joe and my head. And so we want to make sure that doesn't happen. We want to keep her very happy with us. So that's why we double check everything we're telling you on this stuff. Now, do all insurance companies pay for remote patient monitoring? Well, this year, as far as we've heard, the only company that has not been paying for remote patient monitoring is WellMed. Joe, have you heard of any others that's not paying? You're muted right now, Joe.
Sorry about that. No, it's just been well met is the only one that we've been seeing issues with.
And WellMed's not even an insurance company. They just process the claims for United Healthcare. Okay. And currently, we have medical offices all over the United States filing grievances with CMS against WellMed and United Healthcare to get them fined because of this. By the way, I don't know if you realize it or not, but Medicare regulations require that all Part C plans cover everything that Medicare Part B covers. And that's something that you need to make sure you're aware of, because maybe you're doing something that you have a carrier, a Medicare Part C plan, and you call them Advantage plans. I call them disadvantage plans. Or you call them Medicare managed plans. I call them mismanaged plans because I do not like Medicare Part C plans. They end up screwing over doctors. They end up screwing over the patients. But if you ever have a Part C plan tell you we don't cover something and you know Medicare Part B does, reach out, let us know. We'll show you how to file a grievance with CMS and get the Part C plan fined basically by the government. And when we're talking about RPM, there's a lot of salespeople out there that's trying to convince folks that, yeah, you can use an Apple Watch, like this watch right here on my wrist right here. Why? Because it will give me the pulse rate on myself. And they even have some now that say they do EKGs with them. Some of the different apps on the watches. This is not considered to be a medical device. So my advice is be careful if somebody walks in and says, "Hey, we've got this watch system. You can use it to do RPM," and it even tells time too. Thing is, folks, you got to be careful whenever you listen to salespeople about this kind of stuff. Make sure that you verify everything. And this, by the way, is where I'm pointing to you on the screen, where CMS came out and said, no, the watch does not meet the guidelines for being RPM. So anytime somebody says that you cannot do something, verify that by going to make sure that they're telling you the truth. Okay, that's why we give you links on everything. Can the patients use their own device and call it in? I've seen two different companies out there trying to promote medical providers to do RPM with the patient having their own device, and that's not allowed either. According to CMS, the medical device being supplied to a patient must be provided by the medical provider, and that device must automatically and electronically collect and transmit the data. It cannot be self-reported. So again, be careful. Again, sometimes sales folks aren't telling you the truth. Sometimes they'll even show you a letter from an attorney. Like that one doctor I was talking to this morning, he said, I got an attorney's letter here from the ultrasound company saying it was legal. I said, well, an attorney's job is to protect their client. Doc, you're not their client. The ultrasound company is. Now, can that ultrasound company get in trouble? Yeah, Medicare is going after those folks too. So just be careful. Just because somebody walks up and hands you a letter that says, hey, this is legal, that attorney, again, is not being paid by you. So you're not their client. So they have no vested interest in making sure they protect you. And I'm sure that Barbara would support everything I'm saying right there because I know that Barbara's watched this kind of stuff closely. Joe, you want to explain to them the type of monitoring we're doing? You're muted, by the way.
Sorry, I keep doing that. I was trying to just stay quiet in the background there. So one of the to kind of preface this too is we own an RPM company. Obviously, it's called Telecare USA. However, any of the information that you're getting right now, you can use this to shop around at other RPM companies. By all means, it's not something where you have to use us. We're not conceited enough to think that you have to use us. Obviously, yeah, we want you to use us, but legitimately, we'd rather help you and not have you as a customer than force you to shop with us or make you think that you have to shop with us. So just know that I always want to preface that because I hate it whenever, I'm trying to learn stuff and it turns into a sales pitch. So just wanted to forecast that to everyone. the devices that we carry, they're all FDA approved devices. And they all transmit the readings automatically for the patient, which means you're not going to have this self-reporting issue like Dawn was just talking about. There's no Apple Watches or anything like that. So most of the devices that we carry, I'm not going to go into too much like detail on that because otherwise it turns into a sales pitch again. But most of the devices that we carry have a built-in SIM card. So whenever the patient slides on the blood pressure cuff, hits the button to send the or take their blood pressure reading, it takes that reading, automatically sends it to an online portal where you can actually take a look at those readings, or you can view a graph and see what the average has been for the last 2 weeks or the last month, or you can get trends on what that looks like over the course of whatever time period that you want to see. What it'll also do is it'll automatically transmit out of range readings back to you via email. So if you have a patient that takes an out of range glucose reading that's too high, that's higher than what you specify you want it to be, it'll automatically send you an alert, and then you can take action on that if you think that's appropriate to take action on it. So, and this is something that should be standard across the board, whether you do business with us or whether you do business with any of the other RPM companies, it should be set up in this similar manner. So the main types of metrics that we're going to monitor are blood pressure, pulse ox, glucose, and weight for like congestive heart failure patients. So those are kind of the main metrics that we're going to monitor.
Exactly. And some patients are going to lie about their numbers. I remember one time around 12 years ago, 13 years ago, I was driving my dad to the cardiologist, and he was over there filling out a form. I said, "What are you doing?" He said, "I'm putting in all my blood pressure numbers for the last quarter." I said, "Dad, you're making them up." He said, "I know. This way the doctor won't yell at me." I mean, does it really make a difference in patient care if they're lying? Well, one of the things is they did a study, and I'm going to show the results of that study, but two of those results was 13% improved medication compliance and an 8% decrease in A1C levels. And this was a study that went on from 2016 to 2019 that the government put on. It also showed a big difference in the number of patients having to get readmits, initial admits, and ER visits. And it was called the CLASS study. So the insurance carriers recognize that this is going to help save them money because, let me put it this way, they would rather pay you $100 and something a month than to pay for one ER visit. A while back, I had to go to the ER again. And when I went to the ER, make sure it wasn't a heart attack, et cetera, because I was having the same symptoms that I had on the previous heart attack. The insurance company, Medicare in this case right here, got a bill for $14,000 for my ER visit. That's outrageous. Medicare would much rather pay you $100 and something a month to keep patients out. It's just pure logistics. Joe, you want to explain these codes right here?
Yeah, sure. So, all right. So with RPM, you're going to use 4 main codes. Okay. So these, and if you need to take a screenshot, write them down if you want to, you can watch the webinar afterwards. But the main codes that you're going to be using are the 99453 through 99458. So 99453 is for the setup of the patient. So that's educating the patient how to use the equipment, when to test, instructions, right? That's also that's going to be billed one time, right whenever the patient first gets into your program. All right, so that's just a one-time use code. The 99454, the 99457, and the 99458, you're going to use those codes throughout the term that the patient is in the program. And the patient can be in the program for as long as you deem it medically necessary. So we've got some patients that have been in the program for the last 4 years. So that's because it's appropriate for them. So that's something that you're going to build the 99454, 457, 458 on a monthly basis on those. Okay. So the 99454, that's essentially for the patient getting over 16 days of testing in a month. It says each 30 days. But it's actually the best way to do that is on a monthly basis. Right. So just like the graphic says here, 16 days of testing. So one thing to note on this, because this question gets asked a lot, is, is that 16 tests or is that 16 days? And it's 16 days of testing. Another question that gets asked on this is, well, what if I have a patient that has blood pressure monitoring and they have glucose monitoring? Well, each test can count. It'll count as a day. So, like day one, you can have a blood pressure test there. Day two, if they just do glucose up by itself but no blood pressure, that still counts as a day. So, as long as there is a transmission from the patient to that online portal in a day, that counts towards your days. Um, so the AMA is working on creating some more codes that'll kind of help out with this as well. So if a patient reaches, if they're under 16 days of testing, they're working on developing a code for that. That way you'll get reimbursed for that as well. However, that's still in the works, and I think that could be some time before we see that actually come to fruition. But for now, it's 99454 for the days of testing. The 99457 and the 99458 are for the service time that the patient gets. So, service time, what is service time? Service time is you taking a look at their readings. It's you calling the patient saying, "Hey, Bob, I'm seeing that your blood pressure numbers are going up. What's going on? Are you not taking your medication?" Whatever the case is, any time that is spent on the care of that patient related to RPM, you can count that as service time. So that gets accumulated in the portal that you have for your RPM portal. And as you document your service time in there, that accumulates and you get it at the very end of the month. So the 457 is for the first 20 minutes of service time. The 99458 is for each additional 20 minutes, but that's a midpoint code. So as long as you reach 10 minutes or over, you can actually build a 99458. So if you think of it this way, since that's a midpoint code, the first 20 minutes plus 10 minutes gets you a 99454 or I'm sorry, a 457 and a 458. So you get two codes as long as you get to 30 minutes. Now, how do you get to 30 minutes? Like I said, it's whenever you're discussing items with the patient, but also if the patient is submitting those 99454 readings, whenever they come into the portal, those readings count as service time because those readings have to be monitored. So that's either done by your staff or our staff, just depending on how the structure is set up. But that's kind of how that works out from a time basis.
Okay. And by the way, whenever folks question about 99458 because it doesn't say anything in the CPT code book about saying midpoint code, every time we've questioned CMS and CMS has said so on their website, they always reference back to the AMA. And the AMA said, well, check what here with Medicare, and if not, just follow our other guidelines. And you'll notice like a 99291, 99292 is additional time is always considered to be a midpoint code. The same thing whether or not we're talking about therapy codes, etc., midpoint codes. Now, not all RPM companies are the same. Some, like as I said, are telling you to go out and buy your own monitor. Some are sitting here telling you to enter into a percentage agreement. Well, we do not recommend that you ever enter into a percentage agreement with any company, not just RPM related, ultrasounds, labs, anything else like that. Because per our understanding, as well as top attorneys in the country right here, that's considered to be fee splitting under Stark, the anti-kickback laws, fee splitting laws in the states, etc. Does RPM, is it limited to specific diagnoses? As of this month, there still has not been an LCD to put out a limitation. Keep in mind that RPM is only 5 years old. That started back in January of 2019. Now, they may come back next year. They may come in the following year and say, okay, you must have diabetes or you must have CAD, excuse me, CAD or hypertension. And it give you a list of diagnoses. But as of right now, if you believe it's medically necessary and you feel like you can justify it to another medical professional of why this is medically necessary, then you're allowed to do it. There is no specific diagnosis listed. And again, I'm not a physician. Joe's not a physician, but I am hypertensive. I'm 7 years post MI. I monitor my own blood pressure daily with one of our devices right here. And I just submitted in a report to my cardiologist the other day, and she looks at that and says, "Hey, you're doing great." Earlier, when I gave her mine, she said, "Okay, by looking at the averages right here, I'm going to go ahead and cut your metoprolol to half in the morning and half at night." And so, cool. Whatever it is that makes your job easier. When we're talking about blood pressure monitoring, let's look at some of these. Well, we already talked about the equipment right here. And Joe, as Joe said, our staff is checking the numbers daily. And it's almost impossible not to get at least 20 minutes in a month as long as the patient's doing daily testing. In fact, I think last month we averaged 72 minutes. I'm going to go into detail on that one a little bit. But these right here are average nurse practitioner numbers in the country because as a medical reimbursement consultant, I have to have the data in every location. And the 99453 is averaging 1763 for the startup or the setup. 99454 is 4191, and then that's also the average for non-physician practitioners. That's 15% less than what the physicians are. 4281 for the 99457 and $34.24 for the 458. And again, that's really 10.1 minutes to an additional 20 minutes. So your average Medicare allowed amount for a nurse practitioner in the country is $118. Now, if you're in California, it's probably going to be 20% higher than that. If you're in West Virginia or Indiana or Mississippi, it's probably going to be a little bit less than that because it's going to vary in the country based on the cost. And our cost is well, Joe, do you want to explain what we mean when we say all-inclusive pricing?
Yeah, well, so what I want to do on that is I think you have a graphic that shows the all-inclusive like package
Oh, you're
and
right, we do.
the essentials. And that's really kind of the thing that whenever we get to that, I want to kind of discuss that because that's kind
Okay.
of the reason I contacted Barbara on this.
Exactly. So I apologize. I jumped the gun on that. I forgot about that graphic you put in there. So you figured net profit, if someone's just getting 1, 5, 4, 5, 7, and 5, 8 in a month, net profit is probably going to be about $41 and something a month, average in the country, or about $500 a year. That's not too bad. And again, if we take the same kind of numbers right here, though, and we look at it right here under the essentials pricing, which is less because you're getting paid 15% less than physicians. So Joe has come up with a program to cut your fee by 15%. We're going to go into detail on that one. You're still looking at over $600 a year per patient, which isn't too bad, especially considering the majority of you have been averaging about 200 something. Also, last month we had 72.2 minutes in average time. Joe, do you want to explain about how we get that?
Yeah, so the 72 minutes that was
You froze up there, buddy. It looks like he's asleep, but he's really there. He's froze up. His internet has problems sometimes. He's traveling the country right now.
am I losing connection here?
You lost connection. Start over on the 72 minutes, please, sir.
Yeah, so the 72 minutes, that's just like the staff doing our staff doing the monitoring of the normal reads that are coming in, the abnormal reads coming in and being sent to the provider. That would be accumulated by, like I was talking about earlier, by providers discussing the blood pressure numbers with the patient.
Joe, I think you're gonna have to turn your video off if you can still hear me. We're gonna have to lose that pretty background you got of that pretty car there because your signal keeps locking up on us. But like you said, this encompasses all the amount of time. And Lydia, you asked a great question. What about the cost of the equipment? I was paying 25 a month on equipment rental per device, and you were losing money. Lydia, with the way our program is, you don't pay unless you're making money, basically. Unless you're able to bill out either a 5.4 or 5.7 codes, you're not paying either of our fees. I mean, our 7710 fee, if you're not be able to bill out one of those two codes. In fact, we're going to go into detail on exactly how it is. But you see right here with 72 minutes, that equates to 3,99458. That's not a bad profit right there, because Medicare increased the number of 99458s they will pay for in June of last year. It's been a year now, in fact, to the number 3 on the medically unnecessary units, as they call it, MUEs. And this kind of gives you a comparison right here between the essentials pricing and the all-inclusive pricing. So let's go on and jump over here and explain to you what the difference is between these. For
Yeah,
years,
all right.
we've been doing 7710. Joe, why don't you turn off your screen so that way we won't lose you? But I still want you to explain this part if you don't mind,
Here, let me see if I can
because you kept locking up on us, buddy.
okay, can y'all hear me better now?
I hear you good.
Okay. All right. So this was kind of the main reason that we wanted to call this meeting with Barbara is what we were noticing is, our all-inclusive rate. So an all-inclusive rate is us doing all of the monitoring of the readings, calling the patient once a month to check in on them because a 99457 requires an interactive communication where somebody needs to talk to the patient, either talk to them on the phone or sending a text message or something along those lines. As long as you talk to the patient, that counts as an interactive communication. So whenever we have our all-inclusive package, we do the interactive communication. So we reach out to that patient on that. We don't discuss any medically related items, like we don't give them medical advice or anything like that. We just mainly help them with the device, but that counts towards your service time. So the all-inclusive package, our normal rate for the longest time, or for the last like couple of years now, has been 7710. And that includes that includes the device, that includes the monitoring portal, that includes our staff's time, and everything like that. So that also had a CPT guarantee. So what that is if we don't generate, or if a 99454 or 99457 is not generated, then we waive our fee. We waive that 7710 charge. And so that's something that we developed, I think, about a year and a half ago. I know somebody was mentioning one of the original programs where it was like $25 for the device rental plus the charge for the monitoring, which was separate. And it kind of worked out to where people, I don't think people were making as much money as they probably should have. So that's whenever we came out with our 7710 charge, but also a guarantee that if the patient doesn't generate a CPT code, that we would waive our fee. Now that's been our fee for a while now, and what I was kind of noticing is the nurse practitioners were having a bit of trouble making money because y'all are getting, kind of you're getting treated like redheaded stepchildren and getting a 15% reduction on your Medicare reimbursements, which, obviously that's no fault of your own. That's something that, it's being done to you. So I was like, all right, well, how can we kind of compensate for that reduction? How can we reduce our cost as a company? That way it's profitable for nurse practitioners. And I was like, all right, well, what if we just reduced our cost by 15%? And I was like, all right, well, I mean, that would take care of it. They would be profitable at that point because they're not paying the other 15%. It compensates for that reduction that they're getting. So I was like, all right, well, how can we do that? So that's where we kind of came together and we talked about it for a bit, and we've come up with a telecare essentials plan. So it's 65.53 per patient per month instead of the 7710, which if you do the math, it's 15% less, right? So the way that we can do that is by getting a little bit of help from you. And what we've noticed is it kind of works out anyways, because what we've noticed is nurse practitioners generally spend more time with their patients. It seems like y'all are a little more present with your patients. You spend a little bit more time with them. You talk to them a good amount. So that's something where we're like, all right, hey, if they're already chatting with their patients on a regular basis, they're achieving that interactive communication. So what we kind of came up with is a telecare essential. So it's 65.53 per patient per month. The monitoring devices and the supplies are all still included, just like they would in the all-inclusive package. Telecare still onboards new patients. That's something that we started fairly recently also, where we take care of onboarding the patient, like calling the patient and training them on how to use the device and making sure that their portal is set up and making sure that their readings are coming through into the portal. That way your staff isn't spending that time. The out of range readings are still sent to the provider in real time. It might be 2 o'clock in the morning, and you'll get an email from the portal saying, "Hey, this patient tested, a high blood pressure reading or a high glucose reading or whatever the case is." Telecare still takes care of monitoring the normal and the abnormal patient readings that are coming in. But the difference is your clinic just achieves the interactive communication with each patient each month. And so what that looks like is pick up the phone, call Bob, say, "Hey, Bob, looks like your blood pressure numbers were this right here, just like we talked about earlier. Are you doing something different? Are you not taking your medication or hey, let's make a slight adjustment. I need you to come into the office or the clinic next week. How's Wednesday sound?" That sort of thing. And as long as you document that, that counts as your interactive communication. We still send the monthly CPT billing report. So essentially, what we do is Telecare takes a look at your service time, the number of days. We run a report. We send that over to you and tell you, "Hey, here's all of your patients, and here are all of the CPT codes that we recommend that you bill." The only kicker on that is since you're responsible for, communicating with that patient and, reminding them to test and getting that interactive communication, since Telecare isn't the one that's generating that time for you, we don't have a way to guarantee our time. And with the reduction in cost, we don't have the CPT guarantee on that package. So that's really the only two differences are the CPT guarantee, and then you would just need to achieve the interactive communication with the patient each month. But it's a 15% reduction in the cost. So if you're already doing what you're probably already doing, you're going to end up making more money off of that one. So that was kind of our intent with developing this and bringing it to market for you.
Excellent. Thank you. You want to explain the charts as well? I mean, the reports?
Yeah, definitely, definitely. So, all right. So within the portal that all of the readings get uploaded to, this is really cool. So within the portal that all the readings get uploaded to, all of the readings are going to go into a field where you can actually run like a monthly graph or a 2 week graph or whatever date range that you select. And this is the actual visual graph that you're going to get to see.
Exactly. I think he froze up again. Where he's traveling right now, and just south of Kansas City, he's got some spotty internet. This particular is a specific report that I ran on a patient myself. These are my own numbers, by the way, so I'm not giving out anybody else's PHI. This past week, before I went and saw my cardiologist, my appointment this past week. In fact, it was Monday of this week. And so you can see that the actual numbers are about there, and the numbers that's indicated in red shows irregular heartbeats, was like that. And one of the things my own cardiologist liked was this page right here that printed out that showed the average, maximum, minimum, standard deviations, etc., for whatever time of day. Because then she can see whether or not she needs to make medication changes for me based upon, well, what I'm taking for the metoprolol in the morning and the metoprolol at night. And like Joe said, sometimes practices, providers like to look at them in a graph situation as well. And as he said, this graph can be weekly, it can be bi-weekly, it can be monthly, it can be quarterly, it can even be yearly, whatever you're wanting, okay? And let's not forget that what CMS said right here on this report, on these studies, this is why they like it, because it is getting better results from the patient. As an OP doing RPM, do I need to be the patient's primary, or what is the best way to work with the primary doctor? Well, seeing that the vast majority of doctors in the country are not doing RPM yet, many of them don't even know that RPM exists because they've got their hands so full with everything else. You can send these reports over to the primary care doctor if you're taking care of certain things, or you can ask the doctor, "Hey, doc, do you mind if I do this on your patients right here?" I don't know what your kind of a practice you have right now, Jithu, on that, whether or not, what your specialty is. What's involved that you as a nurse practitioner or as a medical provider are going to be doing? First off, you sign, it's a month-to-month agreement. There's no long-term agreement, no long-term commitments. We have to make sure we're giving you a valid value for your money every single month, and we're taking care of your patients. Otherwise, you'll go elsewhere. So that's why we do it on a month-to-month basis. Prepare a list of which patients should be tested for. I talked to a doctor today, Dr. Gigi Davis over in Tennessee, and Gigi said, "What if I make a list of my patients right here? Will you help us contact the patients and explain the program?" Sure, but you have to be the one that makes the list, because we can't make that medical decision that these patients need the service. Only you can do that as a medical provider. And again, we're looking for hypertension, diabetes, congestive heart failure, pulmonary issues, morbid obesity, not just typical weight loss, okay? And then we ask you to complete a protocol sheet. Our staff's going to give you a list and say, okay, for your diabetic patients, when do you want to be notified if the blood glucose is below this or over that? Like one of our doctors in Arkansas, he likes to be notified if it's more than 250 3 times in a row, or one time, if it's over 400, he likes to be immediately notified. And so then we reach out to Dr. Ali in those particular cases. If a patient's oxygen level is at 85 or below, they want to be notified. If their blood pressure drops down, like mine dropped, what was it, about 3 weeks ago, 70/40. So that would definitely flag it. Okay. As the patients come in, we need you to explain to the patients why it's so important to do daily testing. Because some patients think, well, I can be testing once a week and it's no big deal out here because they're not changing much. But those patients are not going to be compliant. Either I'm going to lose money, or our company is, or you're going to lose money if we're not getting that patient testing, because we want to make sure that you're stressing to the patient why the testing is so important, and hand them the appropriate monitor before the patient leaves. Now, what is involved that your staff's going to be doing? As they're handed the monitor, they're going to take the serial number off of a box, stick it on the registration page. They're going to note the patient's name and account number on that registration page. They're going to get the phone numbers on the patient. And they're going to have the patient sign right there saying, "I understand, I am agreeing to be testing daily." And tell the patient to expect a phone call from our personnel, because our personnel are going to be the ones calling. It's going to be Jasmine calling the patient to explain to the patient exactly how to test. Jasmine's going to watch the patient test on the phone right here. They're going to transmit the data. She's going to see it come across on the computer. She's going to make sure the patient knows how to reach out to us if they have any questions on our 800 number. In fact, before the patient leaves your office, we ask your nurse just to take just a moment and take the patient's phone and go ahead and put Jasmine's number in there and say blood pressure monitor or glucose monitor or whatever. Then whenever Jasmine calls them, they're answering the phone, because sometimes patients, they're like my wife, they don't answer the phone unless they know who it is. Okay. And by doing that, we find that we're getting much better compliance out of the patient. Pat them on the head and send them out the door with a monitor. And that's pretty much what your staff's going to be doing. They'll fax that to us, and then we're going to be reaching out to your patient. Now, what if your patient loses the monitor? Well, they're agreeing that they're going to sign an agreement, by the way, saying that in the event that they lose a monitor, they accidentally take it to the pawn shop, or they take it out to the lake and they drop it in the lake or something right here, that they'll be responsible for $100 device fees. We don't worry about the warranty because we have a warranty on every one of them. And we have less than one patient a month across the country that's charged that fee because they lost it or did something to it. I think the last time was when a patient took the device with them when they moved. The doctor's office sent them a bill and they sent the device back because they didn't want to pay that $100. Okay. So it's not like we bill very many patients on that. You're going to be the one doing your own billing. I do not, as a reimbursement consultant, literally to tens of thousands of people around the country, advise you ever let other companies do your billing for you unless they're a billing agency. Meaning that if somebody's providing a service for you, don't let them do the billing. There's inherent problems with that right there. About the 5th of each month, we're going to send you and your biller a report. And it's going to show you from the previous month which patient should be billed and whether or not the patient had at least 16 days. Like, for instance, notice right here, Clark Kent only had 4 days of testing, but did have 20 minutes. So in that case right here, we went ahead and billed, because we got at least 20 minutes. But on Bruce Wayne right here, we did not get 16 days of testing out of that patient. We didn't bug them enough when we were calling them, or you didn't bug them enough when your staff was calling them. And they only had 19 minutes. So you'll notice that there's no charge from us on that. So that's where when we're doing our full inclusive system, we don't bill you unless you're able to bill one of those codes. So that's usually about the 5th of each month, you get a report like this. And then on the 25th of the month, well, right about the 25th, depending on holidays, etc., we're going to do an electronic check on ACH on it for what you owe us for the previous month. This way you get a chance to get paid before you ever have to pay us. Because as reimbursement consultants or revenue consultants, we understand how important cash flow is there. Now, again, you may say, well, can I pay a percentage basis? No, we do not do a percentage basis. I don't recommend you do a percentage basis with anyone. We have some patient that's still have the same monitor that they got 5 years ago back in 2019 on this. And if you ever want to, you can schedule by going to donself.com/schedule and ask me questions on this right here. And it's a free 15 to 30-minute call. You say, but what if I'm using another company? I just want to call you about the billing. Look, if you're part of Barbara's group, I'm not going to charge you for that 15 to 30 minutes to answer questions, even if you're using another company, because we're fans of Barbara. And so if we're fans of Barbara, we're fans of you. Okay. You can also schedule a 90-minute Zoom call with us to discuss all of your practice. And on that, you only pay us if you believe we've increased your income by $50,000 a year. Now, how do you reach us? It's real simple. You can send an email to joe@telecare-usa.com or just call 877-DON-SELF. That's 366-7353, or go to our website, donself.com. Now, I mentioned at the beginning of this call that we're doing a 14-city tour. I'm not sure when I'm going to be able to get back on the road again, because as you'll notice back here, I've got one of those little carts back here because I've got to have another knee put in on my left-hand side because this knee's been breaking the bones, literally. So I'm not sure what cities, how soon I'll be able to get out. But right now we're scheduled for the end of July to be in Schaumburg, Illinois. And then from Schaumburg going in August to San Diego, and then up to Bellingham, Washington, and then to Tampa, Florida, and St. Louis, Missouri, then Grand Rapids, Michigan, Toledo, Ohio, and Cherry Hill, New Jersey. You say, well, what are you teaching in these things? We're doing 8-hour seminars on denial management. On a little side note, y'all need to understand something. Every one of you are getting medical record requests for post-payment. After the carriers have paid you, they'll come back and ask you for medical records, and they may request 30 records, 50 records, 120 records, etc. And that's illegal for the carriers to do that. They're not allowed to request more than 10 records from you by federal law. And then are you required to send out those records? No. And that's what we talked to you about during this 8-hour class that we're teaching. How to not send those out. You don't have to hire an employee to do nothing but send these out, because all you're doing is opening yourself up to audits. And you say, well, what if I don't send them the records? Well, I get in trouble. No, they're violating the law when they make these requests, because they're asking you to send records to people they shouldn't. And that in itself is against the law. And that's what we go into detail. You say, is it worth traveling? Like Lauren, in fact, I believe Lauren was probably on this call right here. She's going to be flying all the way from New York from New Jersey over there, all the way to Chicago, Illinois, to attend this thing. And we've had people go from Maryland down to South Carolina to attend it, and from Florida up to Georgia. And the ones going in San Diego, we got people flying in there from Denver, Colorado to attend. That's how important this data is. So if you ever want to, in fact, I'm thinking, Barbara, maybe we need to have a denial management webinar where we talk about how to handle the denials as well as these record requests sometimes in the next couple of months, because I think a lot of your practitioners are getting ripped off from these insurance carriers, and we got to teach them what they can and cannot do. Is that
Yeah,
would
we're seeing a whole lot of questions on that.
okay? So I'll be more than happy to help you in those areas, because I believe that there's a real problem. As far as do you need the patient's primary as far as doing this right here? Ask the patient, are they getting remote patient monitoring from their primary care doctor? If not, you can do it. You're not limited to specific specialties for this. Someone asked earlier whether or not mental health can do this. There's really not an appropriate PM metric right now for mental health. I know that we've had a couple of mental health providers, because I've got a lot of mental health providers that's on retainer, try to do RPM or want to do RPM just to monitor the level of the patient's anxiety meds and whether or not that's raising their blood pressure. The problem is we've had two different ones I've seen audited for doing that whenever they were doing it as far as monitoring for possible mental health problems. In both cases, they really had a big fight with the auditors. So my advice is not really. There's other things you can do in mental health to generate income, like cognitive testing, cognitive assessment, care planning, that we do a lot of teaching on that. So that may help you in that regard. Okay. What other questions we have? Joe, are you back?
Yeah, sorry for the connection issues. My internet is not happy with me apparently. One thing I want to add is I do see that we do have a couple of a few actually telecare clients that are in the meeting right now. So I just wanted to mention to everyone is even if you are a current telecare client, the essentials package is open to you as well. So if you're like, hey, you know what, I'm already reaching out to these patients. I don't need you guys to do that, and I'd like to save the 15%. By all means, more power to you. Like, just let me know, and let's reduce that cost for you. I'm totally on board with that. So just let me know on that for sure. Also, another thing that we didn't mention earlier, that I just realized is the 99458. We never mentioned that you can actually bill up to 3 units of 99458. So that's something that is that can be valuable right there, especially if you're spending a good amount of time with the patient. You should get compensated for your time, right? So that's something that you can bill up to 3 units of those. The other thing with that 99458 and the 3 units, that was just released in July of last year. Okay. So that's within the last year, Medicare came out and said, hey, send us 3 of these things. We'll pay you even more. And that is an indication that Medicare wants you to be doing RPM. They want this to be done. This thing's been around for 5 years, and they just said within the last year, hey, here's some extra money for you. They're putting the carrot out there for you more and more. So use it, go for it, chase it.
Exactly. Normally, when you see Medicare cutting back on payments and cutting back on coverage, that means that they don't want you doing it. When they're throwing more money at something like this, chronic care management, some other services, that means Medicare sees a value in it.
Don, I want to bring up a question, Don and
Sure.
Joe. One of the things that I hear from people is, oh, I need to wait until I have more patients. And I'm wondering, is there a minimum number of patients that would qualify for the program that they should have before they get started on the program?
Yeah. So on that one, that's a good question. It's kind of a double-edged sword. Okay. So there's not technically any minimum number of patients. Like we have some clients that only have a few patients, right? Now, whenever you've only got a few patients on the program, it's a little more risky, right? So if you have one or two patients, if you only have five and you have one or two patients that are not submitted to, then that's a bigger impact on your overall, your overall bottom line, right? But if you have 50 or 100 or 200 or whatever the case is, obviously a couple of patients that are not compliant, they're not going to have as big of an impact on your revenue, on your bottom line on that. So typically we like to see about 30 starting off. However, that's not set in stone. Like I said, we do have some of our accounts, some of our clients that work with us that only have four or five, and that's going to happen. It is what it is at that point, right? You just want to be conscious of making sure to really forecast to your patients, to make sure and submit their readings regularly. In fact, Navarre, which Sherry is actually on this call right now, she does a fantastic job of that. So I've got to give her kudos. I got to give her credit where credit's due. Whatever she tells her patients, they do a very good job of submitting their readings every month, and that probably gives her great data to work with and really give that patient a good experience and really take care of them. So I know that was a little bit of a rabbit trail, but um, the short answer is no, there's no minimums.
Lydia asked a good question too, saying she does house calls. It's kind of like Shamika. Shamika in Grand Prairie does house calls, and she takes the monitor with her. Um, I believe Sherry does too, doesn't she? Yeah,
I
doing
think
house
so.
calls.
I'd have
And
to ask her.
I'm looking at my list of
Yes,
patient
she
list
does.
of clients up there, and most of our nurse practitioners are working on house calls, and they're taking them with them to the patient's homes.
Excellent. I know there's a couple of people on tonight that were, like Debbie down in Florida, she's looking at house calls. And so this would be really good for her. So um, thank you so much. This has been great. Um, I see a question in the chat. Yes, the replay will go out, and I will be sending that to you, an email to you with a link to the replay as soon as I have everything.
Okay.
Okay.
This is a good question also. If you're doing CCM and you want to do RPM, yes, you can do both in the same month. Just
Okay.
make sure that you're not double dipping. You got to make sure that the time spent on RPM is not counted towards CCM and vice versa. So you can log them into different portals, or just make sure that you specified on this one phone call I did with a patient for CCM today. I spent 15 minutes on their chronic conditions, and then we spent 4 minutes going over their blood pressure readings, etc. And so that's how we take care of it. And we're working very closely with the CCM company. In fact, we were on the phone with them today about offering a joint package to clients wanting to do both. So you're able to welcome, we'll be more than happy to talk to you about that as well.
Yeah, and Lydia, just to kind of elaborate on that, is our our portal, the RPM portal, has an action log section where you're going to document your time there. And then that at the end of the month is going to get counted towards your RPM time. So you're obviously, if you're logged into that, you're not going to be doing any documentation in our portal related to CCM monitoring. So that would be the method. That would be from an operations standpoint. That would be how you would delineate those two services and keep yourself safe. And then what you can do is you can actually export that documentation from our portal. It's like 4 clicks. You can export that, import it into your patient's chart in your EMR, and then you've got your separated documentation there.
Jacqueline, this is the way you reach out to us on that patient you're talking about. Reach out to donself.com, click on schedule at the very top of the page, or send an email to Joe, or send an email to me, or give us a phone call. We're pretty well available any way you want to reach out to us, except the Ouija board. The Ouija board's not working right now. Okay.
Oh, I wish it was.
But when I was growing up, my mom believed in the Ouija board 100%. But then she was also going to tarot card readers and other stuff. My mom had the weird beliefs on that kind of stuff. Bless her heart.
Jacqueline, you can also reach out to Barbara as well. And, I'm sure Barbara has our contact information too. So I'm sure she can give a warm introduction, and that's another avenue that you could take as well.
Yeah, absolutely. And of course, with the replay, I will have all the links, all the contact information so that you'll be able to get to it. So, Don, Joe, thank you so much for talking to us again. And yes, Don, when you have, with everything that's going on with your travel and it sounds like some surgery coming up and stuff, let me know some potential times that we can really do something about the denials, because that is a big deal. I know we talked about some of that a few months ago, but those questions come up a lot about, like today there was a discussion about codes that are, some of the prolonged visit codes that are no longer covered. And then I guess United Healthcare is not covering some of the G codes and, the complexity codes now. And so having an update on coding is always a good idea. And yeah, so great.
I would definitely reach out to you in the next day or so here, I promise you.
Yeah, yeah. And you guys take care. So to everyone else, happy summer. I hope you have a good summer. I hope you don't boil. It is pretty hot in a lot of places and it's getting hot. And I see one more question came in. I don't know if you want to take this now, Don, or send us a
I'll
response
answer it.
later.
Yeah. Our people that we employ all work, and they're all in the United States, by the way. We don't have any of our employees overseas. I've got a real problem with that because of HIPAA, so be careful there. All of ours are our employees working for us. They're regular employees like anybody else. They're not even contract labor. They're all personal employees we take care of.
Yeah, and that's actually, to touch on that too, is, if you do shop with another RPM company, if you do that, make sure that everything is being done within the United States. Otherwise, you're going to run into some problems there. Also, just to kind of mention this, Sherry mentioned in the chat, I document 2 to 5 minutes per patient each week to review the results. 5 minutes if I print them for an upcoming visit. 1 minute per abnormal reading, and email, and 5 to 10 minutes per patient phone call by herself or from her staff, which is fantastic. That is spot on. Can't give you enough praise on that one. So great
Amen. I
job.
wish all of our clients did that, Joe.
Yeah, no, that's fantastic. And that's one of the things I was talking about earlier is nurse practitioners. Like I said, y'all tend to actually, I don't want to say you care more, because I might ruffle too many feathers saying that, but it's I love that y'all care so much.
We really do. We
Well,
appreciate
I'll say it regardless. It's not going to ruffle feathers. I think one of the gifts that patients receive when they work with nurse practitioners is that we listen to them, and they really do understand that we are there to care for them. And when we do that with our patients, they are certainly going to do whatever they can to make sure that we stay their provider.
Yeah,
So
Exactly.
very
there
true.
you go.
Lydia, you bring
So
up a good point,
yeah.
about understanding. If we have a client that has most of their patients up north in New Jersey, then we'll have Carol up in New Jersey talk to them. So therefore, those Yankees understand each other. No, I'm just kidding. Uh, and we also have like Jasmine and a couple of others that speak Spanish as well. So if your patients need to be somebody that's going to be their language, we have that covered. But every one of our employees are located in the good old United States. And as Joe said, if you're using someone to provide a clinical service and that person is not physically in the United States, then if you ever get audited, you're going to be giving money back and possibly looking at False Claims Act. Okay. This is something that the OIG has been going after because so many people trying to save money by using services overseas to provide clinical services. And that is not allowed by Medicare, Medicaid, or TRICARE. The federal government does not allow that. So,
Well, you and I are going to have another chat about that.
okay.
Something else to talk about. All right,
There we go.
everyone. So I'm going to say again, good night. Have a good summer. Stay cool. And I will be in contact with everybody with the replay. So have a great evening. And thank you, Don and Joe.
Thank
All right.
you.
Thank you
Bye-bye.
all very
Alrighty.
much.
Bye-bye now.
All right. Cheers. Bye.